What if the pill you take to feel better is the very thing draining your energy, muddling your memory, or putting you at risk of a preventable emergency? I don't say that to scare you. I say it because hidden in plain sight are medications that quietly do harm in older bodies, even when they're perfectly appropriate for younger adults. Researchers and geriatric clinicians have been waving a red flag for years. Adverse drug reactions send staggering numbers of older adults to the ER every year, and so many of those crises never needed to happen. No one has time during a 15-minute visit to unpack every risk, so families are left wondering why dad got suddenly confused, or why mom, steady all her life, is falling. Today, I'm going to walk you through 5 medication categories that deserve a closer look after 65, what the science actually says about their risks, and safer strategies you can bring to your next appointment. Let's start with a familiar friend that isn't so friendly in later years: the over-the-counter PM pills and old-school allergy tablets that promise sleep and relief. The ingredient in many of them, diphenhydramine, the same thing you'll find in classic allergy meds and in bedtime combos, belongs to a group called anticholinergics. These drugs block acetylcholine, a chemical messenger your brain uses for attention, learning, and memory. When you're 30, a dose may wear off quickly. When you're 70, your liver and kidneys clear it more slowly, so it lingers, and the effects stack up. That's why a nighttime dose can still fog your thinking and slow your reaction time the next morning. Studies following thousands of older adults have linked long-term, cumulative anticholinergic exposure with higher dementia risk. The twist? Many people don't realize they're taking the same class from different bottles: an allergy tab by day, a PM combo at night, creating an invisible double dose. Here's the practical pivot. For allergies, newer, non-sedating antihistamines like cetirizine or loratadine are less likely to cross into the brain and tend to be better tolerated in older adults. For sleep, the goal isn't to knock the brain out, it's to restore a healthy sleep drive and rhythm. Cognitive behavioral therapy for insomnia, CBTI, has excellent evidence and zero medication side effects. It teaches your body to sleep again by adjusting timing, light exposure, and unhelpful habits. If a supplement is considered low-dose melatonin, often in the 0.5 to 1 milligram range taken a couple of hours before bed, can help with circadian timing, but more isn't better. Work with your clinician on a slow taper if you've been using diphenhydramine or similar meds often. Sudden stops can rebound your symptoms. And always scan labels for PM, nighttime, or sleep blends. If acetylcholine blocking is the hidden culprit, knowing where it hides is half the battle. Now, let's talk about the heartburn helpers that turned into everyday habits: proton pump inhibitors, or PPIs. They're incredibly effective at reducing stomach acid, which is life-saving for ulcers and severe reflux. But acids exist for reasons. Acid activates enzymes, helps you absorb nutrients like calcium, magnesium, and B12, and kills harmful bacteria before they settle in. When acid is suppressed for months or years, ripple effects show up: weaker bones from impaired mineral absorption, more infections in the gut because bacteria pass through unchallenged, and possible cognitive impacts observed in large observational studies. In older adults, fractures after a fall can be catastrophic. That's why long-term automatic PPIs, just in case, deserve a rethink. Many people were started on a PPI during a hospitalization and never reassessed. Others refilled out of habit, long after the original trigger resolved. What does stepping down look like? First, identify why reflux is flaring. Smaller, earlier dinners reduce nighttime backflow. Leaving 3 hours between your last bite and bed lets gravity work for you. Elevate the head of your bed by 6 inches. Not just extra pillows. Think wedge or risers to keep acid where it belongs. Notice your personal triggers. Coffee, chocolate, alcohol, mint, fatty meals, and spicy dishes are common, but everyone is different. Gradual tapering under medical guidance can reduce rebound acid. Some people transition to as-needed H2 blockers for milder symptoms. And alongside this, consider bone health. Adequate calcium and vitamin D from food, weight-bearing movement, and balance training. If a PPI is clearly needed long-term, say for complicated ulcers or severe erosive disease, aim for the lowest effective dose and schedule regular check-ins to ensure the benefits continue to outweigh the risks. The message isn't never, it's mindful. If you've ever been handed a prescription for anxiety or sleep and heard names like alprazolam, lorazepam, clonazepam, or diazepam, you've met benzodiazepines. They work by enhancing GABA, a calming neurotransmitter, and they can feel like relief in a bottle at first. In older adults, though, benzodiazepines are consistently associated with more falls, more confusion, slower reaction times, and dependence that creeps up quietly. Observational research tracking thousands of older people over many years has linked benzodiazepine use with higher rates of cognitive decline. Even short-acting versions can cause next-day effects in older bodies, and long-acting ones can hang around for days, layering sedation on sedation. The Beers criteria, a respected guideline for potentially inappropriate meds in older adults, flags benzodiazepines for these reasons. If you or someone you love is already taking a benzodiazepine, please don't stop abruptly. The nervous system acclimates quickly, and sudden withdrawal can be dangerous. The safer way forward is a slow, methodical taper, often about 10% dose reductions every week or two, tailored by a clinician who knows your health picture. While you taper, build a toolbox that makes the medicine less necessary. Cognitive behavioral therapy for anxiety and for insomnia is highly effective. Gentle but consistent exercise rebalances stress hormones and improves sleep drive. Mindfulness practices, paced breathing, and guided relaxation retrain the body's alarm system. Some people benefit from switching to a longer-acting benzodiazepine as a bridge during tapering, to smooth peaks and valleys. Think of this as teaching your brain to produce its own calm again. It takes patience, but I have seen so many older adults regain clarity, steadiness, and confidence as the dose goes down. Now to the medication category that changed modern pain treatment, and not always for the better, opioids. Names you'll recognize include oxycodone, hydrocodone, morphine, and fentanyl. They absolutely have a place in acute, severe pain, trauma, and certain end-of-life settings. But long-term for chronic non-cancer pain? That's where risks grow and benefits shrink. Older adults receive a large share of opioid prescriptions, and with age come increased sensitivity to sedation, dizziness, constipation, and confusion. Falls spike, particularly in the first weeks of therapy when the body hasn't adapted. Constipation can become so severe it leads to bowel obstruction or urgent interventions. There's also something counterintuitive called opioid-induced hyperalgesia, where the nervous system becomes more sensitive to pain over time. And the cognitive fog so many describe is not imagined. Studies show measurable declines in attention and memory with ongoing opioid use. A different path is possible, and it often works better. Step 1 is diagnosing the pain, not just muting it. Arthritis, spinal stenosis, neuropathy, old injuries, each benefit from specific strategies. Step 2 is building a layered plan. Physical therapy restores mechanics, strengthens support muscles, and teaches safer movement patterns. Cognitive behavioral therapy for pain helps the brain interpret signals with less distress, reducing the perceived intensity. Gentle practices like Tai Chi or yoga improve balance and reduce fear of movement. Acupuncture has moderate evidence for certain pain syndromes. Topical treatments, lidocaine patches, diclofenac gel, target local pain with minimal systemic effects. When medication is appropriate, options like duloxetine or certain low-dose tricyclics can modulate pain pathways, particularly for neuropathic pain. We need to revisit anticholinergics one more time, because the strongest versions are often prescribed for a very personal, frustrating problem: overactive bladder. If you've heard names like oxybutynin, tolterodine, or sulfasalazine, those are classic bladder anticholinergics. They relax the bladder by blocking acetylcholine. Remember, the same messenger your brain uses for thinking. In older adults, that blockade doesn't stay below the belt. It reaches the brain. Large studies have tied long-term use of strong anticholinergics to higher dementia risk, and short-term trials show measurable declines in memory and attention within weeks of starting. The tragedy is that the symptoms, urgency, frequency, leakage, are embarrassing, isolating, and absolutely deserve treatment. But many people would not choose improved bladder control at the price of foggier thinking if they knew there were other ways. What are those options? Behavioral and physical strategies are powerful here. Bladder training increases the time between trips gradually, retraining the detrusor muscle to tolerate stretch. Pelvic floor therapy strengthens the muscles that support the urethra. Consistent practice can cut leakage episodes dramatically. Timing matters. Shifting diuretics earlier in the day reduces nighttime urgency. Limiting evening fluids and alcohol helps too. Identify irritants, caffeine, artificial sweeteners, acidic juices that make your bladder more reactive. For some, scheduled voiding prevents just-in-case habits that shorten bladder capacity over time. If medication remains necessary, newer agents like mirabegron or Vibegron activate a different receptor and don't block acetylcholine. They can be effective without the same cognitive burden, though they still need medical oversight, especially if you have high blood pressure. The key is this: you're not choosing between confusion and continence. Quick pause while we're on a roll. If this is helping you connect the dots, take a moment to subscribe to Senior Vitality Pro and tell me your age or where you're watching from in the comments. I read them and shape future topics around what you need most. Your lived experiences help me decide what to cover next. Let's step back and ask, why do these medicines behave differently after 65? Aging changes pharmacokinetics, the way drugs move through the body, and pharmacodynamics, the way the body responds. Liver blood flow decreases, kidney filtration slows, body composition shifts toward more fat and less water. That means fat-soluble drugs can hang around longer, and water-soluble ones can reach higher effective concentrations. The blood-brain barrier gets a bit leakier, so agents that barely affected the brain before can now cross and cause confusion. On top of that, many older adults live with multiple conditions and take multiple medications, so interactions multiply. A sedative plus an anticholinergic plus a glass of wine isn't just three things. It's a compounded risk for falls, delirium, and hospitalization. None of this means no medications. How do you spot subtle side effects before they become an emergency? Start with patterns. Is there new confusion, especially in the evening? More daytime sleepiness or staring spells? A recent fall, near fall, or increased reliance on furniture when walking? Worsening constipation, new urinary retention, or episodes of dizziness when standing? Bring a complete list of everything taken, prescriptions, over-the-counter pills, supplements, and PM blends to every appointment. The label on the front of the box can be misleading. The active ingredient list on the back tells the real story. For couples or adult children helping parents, a shared medication chart taped inside a cabinet can prevent double dosing and help you notice when something creeps in. Ask specifically, is this still needed? Is there a lower dose? Is there a non-drug option we haven't tried? A good clinician welcomes those questions, and if they're rushed, can schedule a focused medication review visit to do it justice. Let's get concrete with sleep, since that's where so many quick fixes start. If your nights are fragmented, first shore up the foundational pillars. Set a consistent wake time, yes, even after a bad night, to strengthen the circadian clock. Get bright morning light for 20-30 minutes, preferably outdoors, which signals your brain that daytime is here. Keep the bedroom dark, quiet, and cool. Reserve the bed for sleep and intimacy only. Avoid long daytime naps. If you must, keep them under 30 minutes before mid-afternoon. Wind down with a low stimulation routine, stretching, a warm bath, gentle reading, so your nervous system doesn't have to slam on the brakes at 10 p.m. If you're awake in bed more than 20 minutes, get up and do something calm under dim light until sleepiness returns. Lying there frustrated trains wakefulness. These changes are deceptively powerful. They rebuild the sleep drive so that medications that sedate aren't needed or can be used rarely and briefly under guidance. For reflux, a similar mechanics-first approach pays dividends. Elevate the head of the bed with blocks or a wedge, not just extra pillows that bend your neck. Eat your largest meal midday. Make dinner light and early. Notice if bending over or tight waistbands worsen symptoms and adjust accordingly. Track triggers for 2 weeks to personalize your plan. It may not be the coffee, but the late-night coffee, or not spice, but fried foods. If you smoke, stopping lowers reflux pressure and improves overall healing. Weight loss as modest as 5 to 10% can reduce abdominal pressure and ease symptoms. Consider mindful eating, slower bites, thorough chewing to reduce gulped air and pressure spikes. If medications are still needed, agree with your clinician on a defined trial period and a specific step-down plan. Mark a calendar reminder to reassess. Without one, PPIs tend to become forever by default. For anxiety, think skills over sedatives. Anxiety in late life often pairs with isolation, health fears, or caregiving strain. Joining a gentle movement class, Tai Chi, chair yoga, water aerobics, adds social contact, builds balance, and calms the nervous system. Brief structured therapies like CBT teach you to challenge catastrophic thoughts and reduce avoidance that keeps fear alive. Breathing techniques aren't fluff. Slow exhale. Dominant breathing stimulates the vagus nerve and physiologically turns down the body's alarm. Nature exposure improves mood. If medication is considered, non-benzodiazepine options may be safer for many older adults, though every choice is individual. And remember alcohol. A nightcap feels relaxing in the moment, but fragments sleep and amplifies next-day anxiety, especially when mixed with sedating meds. Small daily practices compound into big relief without sacrificing balance and memory to a tranquilizer. Chronic pain calls for a team, not a single pill. If joints ache, a physical therapist can assess gait, shoe support, and joint protection strategies. If back pain flares, core strengthening and hip mobility work often relieve pressure on irritated nerves. For neuropathic pain, burning or tingling, tools like duloxetine, certain tricyclic antidepressants at low dose, capsaicin cream, or lidocaine patches can be targeted and spare sedation. Heat, cold, and TENS units can be adjuncts you control. Sleep, mood, and pain are a triangle. Improving one eases the others. Consider a time-limited trial of acupuncture or a gentle yoga class tailored to older adults. And keep joy in the plan. Activities that engross you, gardening, puzzles, music, shift attention, and reduce the brain's amplification of pain. When pain is stubborn, a comprehensive program beats escalating opioids every time because it preserves function and thinking. Back to bladder health for a moment, because confidence to leave the house is priceless. If getting to the bathroom in time is the hurdle, rearrange your environment for success. Clear pathways, add night lights, place a commode within reach if nighttime distance is the issue. If urgency is triggered by running water or key in the door moments, practice urge suppression techniques. Stop, stand tall, squeeze the pelvic floor, breathe, and wait for the wave to pass before walking calmly to the toilet. Schedule voids proactively, every 2 to 3 hours, to avoid the panic dash. If pads are part of your strategy, choose breathable designs and change regularly to protect skin. For those considering procedures, talk with a urogynecologist or urologist about options with a better brain safety profile than anticholinergics. The message here is freedom. You can reclaim time, travel, and social life without trading away your sharpness. If you're thinking, this is overwhelming, you're not alone. Start with one step, a medication checkup. Make a complete list using the actual bottles. Circle anything with PM, anything ending in amine that's used for allergies or sleep, any benzodiazepine, any opioid, and any bladder medication that's not one of the newer beta-3 agonists. Add PPIs if you've been on them for months. Bring that list to your clinician and say, "Can we review these together with my age in mind? What can we reduce, switch, or replace with a non-drug approach?" If you're a caregiver, ask about a formal deprescribing plan. There are established protocols that step down medication safely. And if you meet resistance, ask for a referral to a geriatrician or a clinical pharmacist who specializes in older adult medication reviews. Aligning the medication list with your current goals can be one of the most impactful health decisions you make this year. You may be wondering about supplements. They're not automatically safer just because they're sold over the counter. Some, like high-dose melatonin, sedating herbs, or multiple products with overlapping ingredients, can compound the very side effects we're trying to avoid. St. John's wort interacts with many prescriptions. Magnesium can loosen stools in a helpful way for constipation, but certain forms can interact with medications or worsen kidney issues. Always include supplements in your medication list and verify dosing and timing. A clinical pharmacist can help you schedule your day so that medicines and nutrients don't compete for absorption. And remember, the point isn't to be medication-free at all costs. The point is to be side effect light and function rich, with each item on your list earning its keep. Let's circle back to those startling statistics we opened with. Emergency rooms see an enormous number of older adults each year for medication-related harms. The most sobering part? Many are preventable with awareness, dose adjustments, and alternatives. Anticholinergics, cloud thinking, and increase fall risk. PPIs, used indefinitely without reassessment, can weaken bones and invite infections. Benzodiazepines sedate in a way that undermines balance and memory. Opioids, outside of carefully selected cases, create more problems than they solve for chronic pain. Bladder anticholinergics trade clarity for drier days when other strategies could preserve both. None of these medicines are bad. They are tools, but tools must be matched to the material, the job, and the person holding them. After 65, the material changes. That's why today's conversation matters. How do you turn knowledge into safer daily life? Set up quarterly brown bag reviews. Gather every pill bottle in a bag and go through them with your clinician or pharmacist. Use one pharmacy if possible so interactions are easier to track. Add fall-proofing to your home. Secure rugs, improve lighting, add grab bars, and keep assistive devices within reach before you need them. Keep hydration steady and fiber adequate to prevent constipation, especially if you're on any med that slows the gut. Track new symptoms with dates so you can link them to medication changes. Share the plan with family so everyone supports the taper schedule and non-drug strategies. Progress won't be linear, but momentum builds. And give yourself credit. Advocating for safer care is brave and wise. I want to acknowledge what this asks of you. It asks for honesty about what's helping and what's not. It asks for patience when you taper instead of quit. It asks for courage to say, "I'd like to try something different," even when a pill feels like the easiest path. But the reward is enormous. Fewer foggy mornings, fewer near misses on the stairs, fewer nights chained to reflux or restroom fears, and more of the good stuff: clear conversations, strong steps, and the confidence to plan ahead. You deserve a plan that respects your brain, your balance, and your independence. And if you're a caregiver, you deserve peace of mind that the support you're giving aligns with the healthiest science we have. As we close, let me leave you with a simple checklist you can act on this week. 1. Scan for anticholinergics, PM blends, old school allergy pills, and older bladder meds, and ask about safer swaps. 2. If you've been on a PPI for months, set an appointment to reassess and build a taper plus lifestyle plan. 3. If a benzodiazepine sits on your nightstand, start the conversation about a slow taper and CBT for sleep or anxiety. 4. If opioids are part of your chronic pain plan, Request a comprehensive alternative strategy and taper roadmap. 5. If bladder symptoms are stealing your freedom, try bladder training and pelvic floor work, and ask about non-anticholinergic medications if needed. Write these down, bring them in. This is not about perfection, it's about direction. And finally, a reminder. This video is educational. Your health is personal, and any medication changes should be made with your healthcare provider who knows your full story. Share this with a friend, a parent, or a neighbor who might be quietly struggling with side effects and doesn't know there's another way. You have more options than you've been told, and you are not stuck. Take the next small step and the next one after that. I'm cheering you on.